We're going to talk about informed consent and what how this is related to our clinical practice. It's a crucial part of what we do because it is part of the discussion that we have with our patients prior to every procedure, but also when we see them clinically. It's a legal requirement to be done for every medical procedure, and in essence, it's a process through which the patients are informed about potential options and everything should be included, and is making a decision together with the patient on the specific procedures that they're going to undergo. The person that should take the consent is ideally the person that is doing the procedure. And this is because this is the right person to deal with a specific situation and explain exactly what is going to happen. In some cases, it might be a colleague of the same level, but in none of the cases should be done by somebody that is not really doing the procedure. So this is a failure of the system and should be limited. And there have been studies in the past that have shown that in IR, we had cases where all this is done by a bunch of people, including the referring physicians, and this is not adequate. The discussion should actually reason the procedure and identify why we're doing this specific procedure, what are the expected outcomes, what we would like to achieve, and what are the potential complications that are related to this procedure. When is this going to happen? Well, we should see our patients in clinic, and this is the time where we should ideally discuss all that and offer the possibility for the patient either to decide at that moment or if they take a decision at a later moment, but be informed about all that is going to happen, because patients see us for a consultation for a procedure. Relatives may be present, and it's actually good. It's something that I would personally, I'm in favor. Clearly, this is a decision of the patient, because the patient should actually involve whoever they believe is required to be present. And the consent, if it's signed on the day of the consultation, can be potentially countersigned when the patient comes for the procedure. And in this occasion, it can, yes, be done by maybe a junior doctor that is seeing the patient just before the procedure. Now, sometimes we have to deal with cases on an emergency basis, and this is a completely different process, because in that case, we might sometimes even act on best interest of the patient, and we don't have the possibility for a trauma case to do all this discussion before that, but this is a very specific situation. We have to, when we see the patient and would like to consent them, we have to identify the reasons that we're doing this procedure, and clearly it should be clear that the IR is somebody that is on board of the decision, and we have to communicate to the patient that we also agree if this is a common decision, or if it might be a decision that's only ours, and we involve other specialties. And in this case, we have to inform the patient that other specialties have been involved. We communicated what we intend to do, and everybody's on board on that. So this is, I think, the ideal management for this. What are the expected outcomes? This is also something that needs to be communicated through the informed consent. For example, we might have diagnostic targets if we're doing a biopsy, curative when we're dealing, for example, prostate embolization, or local treatment, local regional treatment with local curative intent for metastatic disease, or palliative when we're doing biliary drainage, or life-saving in some cases if we're dealing with cases of bleeding embolization, in bleeding in trauma cases, or patients that have to be dealt on an emergency basis. So all this a little bit differ because of the variability of the portfolio of the cases that we do. But every procedure we do has a specific outcome, and this has to be communicated to the patient. Now, the technical details is something that the patients are not that much interested in. So we might describe the access, we might draw a sketch if we would like to, we might have a video. In some cases, this is always useful. The patient would always ask how long is going to, in most of the cases, they will ask for how long the procedure is going to last, and it's probably something that they should be aware of, how much the procedure is expected to last in most of the cases, if they're going to be awake or not, if they're going to receive general anesthesia. This is something that they are also always interested, and we have to communicate how we're going to regulate the potential risk factors. So, for example, anticoagulation, or identify potential allergies to contrast or whatever else we're going to use. So these are have to be addressed before the procedure. And regarding potential complication, we should be very transparent and informative. Actually, we have to put things in the right dimension, because sometimes if we get referred patients from other physicians, then our procedures appear as maybe relatively simple, which they may not in some cases. So we have to have a pragmatic approach of the potential complications that might occur whenever, even if we're doing a simple thing like a lung biopsy, that might end up wrong with several problems. So this is something that the patient should be aware. They should be aware that there might be risks. They should be aware of the fact that they might in the hospital or maybe end up in ICU in some cases. Of course, we have to communicate that all this is done for a specific reason. And even though our procedures are minimally invasive externally, internally we have to be very precise in what we do, either placing a needle or blocking a vessel or doing a thermal ablation. So all this has to be done and be crystal clear. And of course, if complications occur, then we have to communicate also the fact that in the majority of the cases, we are in position to deal themselves as IR without involving other specialties. And actually, this gives them to the patient a different approach. They identify us as treating physicians, because we are the one that were dealing with the majority of the complications that might occur. And this is crucial to communicate when we do the consent. When do they sign? Well, when everything is clear, of course, we have to ask the patient if they understood what we said, if they understood what they communicated, if they would like to ask any questions, potentially, and if they agree with a specific plan that is placed for their treatment. And they could sign on the day of the consultation, or they would potentially sign another day or the day of the procedure in some cases, if we would like to think of that, about that. And in that case, we might also help them to make the decision, offering some decision aids like handouts of video or resources that might help them identify better the procedure, get acquainted to what we're planning to do, look at the internet, identify what would be the best for them, so they might have the right time. So all this would be in a constructive way to offer the right approach for the procedure. Now, we might encounter some specific situation like the use of surrogates, and there would be some legal representation of the patient, and this the specific guidelines and a framework that is usually locally implemented, and we should follow that. We might have language barriers, and in this case, we might use an interpreter. And I guess again, the use of an interpreter is something that is locally described, so it's trust. Its hospital has its own rules for the interpreter. They should sign also the consent form if an interpreter is used. If we're dealing with the emergency cases or intubated cases, we might have to act in best interest. And in this case, other specialties might also countersign the consent form and say, we're doing a trauma patient, we have to do a TEVAR, or we have to do an embolization. Then the patient is intubated, they might not even have a name. So in some specific cases in the hospital, and then we have to deal with that. And another sensitive situation that we might have to deal with sometimes is when patients are coming with complications from previous procedures, maybe surgery, and then they ask questions like, what was done wrong previously? Could we have prevented that? And things like that. We have to be always professional and keep a balanced approach and identify the way of communicating to the patients that whatever was done was for their best interest, and offer no judgment on what was done previously. And all this is part of what we offer for the patients as a clinical specialty, and get more experience on talking to patients and dealing with situations that might be sensitive involving other specialties, but of course also always identifying ourselves as a treating physician that is dealing with the problem and is able also to deal with the potential complications. Thank you very much for your attention. And if you have any questions, then attend our sessions for from the clinical task force in CIRSE 2024. Thank you.